So Joe, following our discussion,
Right.
it looks as if we start with recognizing the patient. We attach that recognition made by the Caprini score to an action plan on how to prevent thrombosis, instruction by instruction, and then create an auditing system so that we understand we're doing it right and we recalibrate our assumptions. So you said it nicely, never kill a friend, never treat a stranger. So go deep into how do you actually go ahead and do the scoring system?
Well, I think first of all, one has to have a face-to-face encounter and ask the right questions. Chart reviews don't seem to work because you never know whoever created the chart and whenever they created the chart, what kind of questions did they ask. One of the biggest pitfalls is not to do this assessment prior to the operation, but wait till the patient gets into the holding area on the day of the surgery. It's absolutely the worst time in the world to talk about asking about your risks and your past history and so forth. When you're in the holding area waiting for surgery, you're wondering how long is the operation going to take? Is the doctor going to have a bad day? How much pain am I going to be in? Will I really get better? How long am I going to be out of work? So this has to be done ahead of time. Now the other thing is that when you go to the dentist, you have to fill out your health history before the dentist will even talk to you, before any type of procedure is planned. That should be the case for surgical procedures too. This information should be filled out ahead of time. In addition, the best way to fill it out is with part of your family. You know, I've gone to the doctor and come back and talk to my wife, and my wife would say, well, did you ask this? Did you ask that? No. Did you talk to the doctor? And that's why you need the family to participate, because when you're listening to the doctor, you're worrying about what that doctor is saying regarding the procedure. You're not focusing on your history as much. So we have a patient-friendly form that one can fill out. And you can fill it out with your family ahead of time. And then when you come to the hospital, the way the form should be completed is by the person responsible for the history and physical of the patient. Admitting nurses don't take histories and physicals. They're not trained to do that. They're trained to look at does the patient have the right pieces in place before the surgery, the blood count and so forth. So it's very important. So that's the first thing, is getting all the information. But there's another point which is equally as important. What does that information mean? And there's several really pitfalls that come into play here. Family history of thrombosis. Blood clots run in families. You may not even have a blood test to show that, but you know, Aunt Tilly had a blood clot, your mother might have a blood clot, your brother might have a blood clot. So blood clots work are in families, so you must make sure that you ask a good family history. The other thing is, there's a very powerful blood clotting abnormality that essentially is where the body develops an allergy to the clotting proteins and rejects them. It's got a fancy name, antiphospholipid antibody syndrome. But what is the key to detecting that? And that is in women who've had obstetrical misadventures, unplanned abortions, stillborn, placental insufficiency, toxemia of pregnancy. Even if there's a 60 or 70-year-old woman who has that history, one has to make sure that they test for this so that that patient doesn't have that extra risk. So you have to understand what the risk factors are. Ambulation. A person has to be able to walk on the leg. You can't have one leg in a cast and not weight bearing, and just because the patient can walk 100 feet with a walker, that's not ambulation. So you have to understand the risk factors.
So what I'm hearing from you is that the major problems that you see when somebody's risk assessing is doing it in the wrong moment, and the solution for that would be doing it ahead of hand and using a patient-friendly form, which the link is going to be down for how to do that. Number two, misinterpreting that the prior history of gynecological problems is actually relevant. And number three, I'm hearing that perhaps it's also often misconsidered that a patient's ambulation is overrated as a protection factor, and maybe even having a boot is really not an efficient calf muscle function, and that should be counted against the likelihood of risk.
Perfectly said.
Okay. So we did a nice paper, I believe, in which we go through this in much more detail. The link below is going to present a more detailed evaluation of how to fill the whole scoring system.
Thank you very much.